we're getting ready to move in to the next 4 presenters from the NIH. They said, oh, we got some new things we want to share with you this year, so we're really excited. I'm going to just introduce Dr. Rachel Gafni, who will kick it off, and then she'll bring up her colleagues as she rolls through. So, Dr. Gafni.
Hello, everyone. Thanks for having me here. Patty asked me to talk a little bit about pediatric hypoparathyroidism because I guess I might be the only pediatrician at this meeting. I'm not really sure. So I'm not really going to be talking so much about NIH research specifically, but I'll be just giving a bit of an overview and some tips if you have a child or you yourself were once a child diagnosed with hypoparathyroidism, and then my colleagues will present some of the current research that's going on. So I just touched this. Yes. So your child was just diagnosed with hypoparathyroidism, so what happens next? So it's really, really important when you are with the provider that they're taking a detailed history of not just your child, but also your family, because when things happen in children, often there's an important family history. They need to perform a very thorough physical exam because there might be associated features with the hypoparathyroidism, and they should always be considering testing the parents because the parent might have hypoparathyroidism and not even know it. And then, of course, performing genetic testing. And so this is not a complete list of the causes of hypoparathyroidism. And I know most people with hypoparathyroidism have had surgery as the cause, but we as pediatricians, when we see people who have children with hypoparathyroidism, it's almost always genetic. And I kind of like to divide it into 3 groups. And I'm not going to go through all of these, but they can be due to disorders of parathyroid gland formation, so genes that affect the development of the parathyroid in the developing fetus, disorders of parathyroid gland secretion, so maybe the parathyroids are pretty normal, but something is causing them not to secrete PTH into the bloodstream appropriately, and then parathyroid gland damage or destruction, such as might happen with surgery or autoimmune disorders. So the other way you can think about hypoparathyroidism is it isolated, so the kid's completely otherwise healthy but has hypoparathyroidism, or is it part of a larger syndrome? So a syndrome is just a group of symptoms which consistently occur together, or a condition that's characterized by a set of associated symptoms. And that's why that thorough history and physical exam is so important. So one of the more common genetic causes of hypoparathyroidism is autosomal dominant hypocalcemia type 1, or ADH1. And I know you heard about that yesterday, and my colleague Dr. Roszko is going to talk about our research at NIH in this patient population. It's a rare genetic form of hypoparathyroidism that is estimated to be present in 1 in 70,000 people. And this is due to a genetic variant in the gene for the calcium sensing receptor, which causes that receptor to be sort of stuck in the activated state. And the body is tricked into thinking that the blood level of calcium is higher than it really is, so the parathyroids don't produce PTH like they're supposed to. And this is an isolated form of hypoparathyroidism. It's not part of a syndrome. I think you heard about genetics yesterday, so I'll just remind you what it means to be autosomal dominant disorder. So in dominant disorders, only 1 copy of the gene needs to be changed. So remember, we have 2 copies of every gene. In autosomal dominant disorders, 1 copy is normal and the other copy has been changed in some way to cause a condition. Hello? Am I touching this right? Okay. So if in autosomal dominant conditions, the child of the person affected, the child will have a 50-50 chance of having the condition as well. And it's very common, as you'll hear from Dr. Roszko, for someone to be the first person in their family to have ADH1, what they call sporadic or a de novo variant. But once you have it, you can pass it to your children. All right, I don't know why this pad doesn't like me. Okay, this is a different condition now called the 22q11 deletion syndrome, which some may be more familiar with the older names like DeGeorge syndrome or velocardiofacial syndrome or Sprinson syndrome. And so this is a syndrome. And this condition is caused by a microdeletion where a small section of the 22nd chromosome is deleted that contains about 50 different genes, including an important gene called TBX1. Rarely somebody can have this 22q11 deletion syndrome where instead of the genes being deleted, there's actually a duplication. So there's an extra piece of the genetic material on that chromosome. And in about 90% of people with this disorder, it's sporadic. So it happens spontaneously. They're the first one in the family. They didn't inherit it. But once you have this one, just like ADH1, it becomes autosomal dominant. So the child of somebody with 22q11 also has a 50% chance of getting that. It's very, very common. It's about 1 in 2,000 to 4,000 live births. And it's a very common variant to see in children with congenital heart disease and also with cleft palate. So there's a huge long list of features of people with 22q11 deletion syndrome, and it can be a little overwhelming if you go on the internet. You see this long list of features, but it's important to remember that in these types of syndromes, you may only have 1 or 2 of these things, or you could have 10 of these things. So it's really, really variable, even within families. The most common things are heart issues, some unique facial features, and underdevelopment of the thymus, which can lead to increased infections, and cleft palate, as I also mentioned previously. In terms of hypoparathyroidism, though, this is somewhat variable. It occurs in about 50% of people have this 22q11 deletion syndrome, but the severity is extremely variable, and it can wax and wane throughout life. There is, just like we have this great support group for people with hypoparathyroidism, there's also an international support group for people with 22q11 deletion syndrome. And it has a lot of great guidelines, things for your providers, for families. So if that's the cause of hypoparathyroidism in your family, I highly suggest you get involved with them. Another genetic disorder that also comes into a syndrome is the hypoparathyroidism deafness renal dysplasia syndrome, also called HDR. And this is due to a deficiency or a change in a gene called GATA3. And so the previous 2 disorders, the first one was a genetic change that caused isolated hypoparathyroidism. The second one was a deletion of a whole bunch of genes that could be responsible for hypoparathyroidism in a child. And this one is, again, a single gene, which is also autosomal dominant, but it affects more than one tissue, not just the parathyroids. And that's because GATA3 is a transcription factor. And what transcription factors do is they regulate how genes function in different tissues. And this particular transcription factor is really important in the parathyroids, the ear, and the kidney. So that's why you can have more than one tissue involved in this disorder. But again, the clinical variability is really different, even within families that have the exact same variant in GATA3. So you could have somebody with hypoparathyroidism and hearing loss, and then they could have a child that had hearing loss and a kidney problem, but not hypoparathyroidism. But the really key thing is that decreased hearing in this disorder is the most common symptom. So if your child has hypoparathyroidism and hearing loss, it's very likely to be this, and the child should be tested for this. But you can also see hearing loss in 22q11 deletion syndrome, and I even have an ADH1 patient who has hearing loss. So, hearing loss is not super uncommon, but it just makes you think. And again, this goes back to your provider taking a really good history, very comprehensive, and doing a good physical exam. Other symptoms can also be affected, like the female genital tract, like there can be duplication of a uterus or other types of developmental abnormalities in the genital tract, and it could also affect the immune system. Autoimmune hypoparathyroidism now is in that group of disorders where the parathyroid glands are damaged. And so in adults, hello. So most typically we see this in adult onset, and it could be associated with other autoimmune diseases, but unlike the previous disorders I mentioned, this one's not associated with a single gene variant. It's sort of a polygenic disorder, and there's a lot of different genetic factors at play that can lead to autoimmune hypoparathyroidism. But in children, we most commonly think of APECED, which is autoimmune polyendocrinopathy candidiasis ectodermal dystrophy syndrome, and that's a big mouthful, which is why we say APECED. And we used to call it APS1, which was autoimmune polyglandular syndrome type 1. And this is a monogenic disorder. So this is a condition, God bless you. This is a condition that is an autosomal recessive variant in this AIRE gene, which means you have to inherit the variant from your mother and your father to have this condition, and your parents would be carriers, but they don't have this condition if they're just a carrier, if they only have one copy of the gene. And this gene, AIRE, is really important for regulating immune tolerance. So if you're deficient in AIRE, it causes your own inflammatory cells to attack the organs within your body, just like other autoimmune conditions, like you know about that with diabetes, type 1 diabetes, or lupus, or these other autoimmune conditions. So this is also an incomplete list from Dr. Lionakis' group at the NIH who studies APECED in detail, and he's going to present some exciting treatment things to you guys. But just goes through some of the autoimmune manifestations that we see. And when most physicians think about APECED, they think about hypoparathyroidism in the first decade of life, adrenal insufficiency in the second decade of life, chronic yeast infections, candidiasis that can persist beyond the infancy period, like thrush in the mouth or diaper rash. But they also identified some new other interesting things that could be a hallmark, could let a doctor or even a dermatologist think about this early on, particularly this urticarial eruption, these hives or skin findings that can present quite young. This is one of our NIH patients who has, this is just some autoimmune conditions like hair loss, alopecia, and he also has those white patches, which are vitiligo. And you can see some patients also have abnormalities in their nails. So lots of genetic conditions, and I think you heard about this yesterday, but currently there is still a free genetic testing program for hypoparathyroidism. It's free to people in the United States and Canada, and it looks at 26 genes, so it's a pretty comprehensive panel. So I would highly suggest, if you haven't had a genetic diagnosis, that you talk to your provider about getting this done. And this is not just for children. You could be in your 20s or 30s, and if you haven't had surgery and you have hypoparathyroidism, I would strongly suggest getting this test. Okay, so now I'm just going to end talking a little bit about approach to treatment in children. So this is a real patient of mine. He's long an adult now, but when he was 8, he went skiing with his family, and they went up the mountain, and he had a seizure at the top of the mountain. And they brought him down into the emergency room and found that he had a very low blood calcium and a high blood phosphate and a very low parathyroid hormone. So while you're waiting, if you or your family member or your friend has hypoparathyroidism and they're getting symptoms of low calcium, I mean, they didn't know that's what was going on with their son, but if you were with somebody and you're waiting for EMT to come or somebody in the hospital, what can you do? So one thing, and I don't know if this was mentioned, but you can have the person breathe into a paper bag. And that's because when you hyperventilate because you're in pain or you're nervous or you're scared or you're going up in elevation to the top of a mountain, which causes you to hyperventilate because there's less oxygen up there, the free calcium that circulates in your blood binds to proteins. So you're lowering your blood calcium transiently because you're hyperventilating. So, all right, come on. So when you breathe into a paper bag, it increases the acid level in your blood, which causes the free calcium to be dissociated from the protein. So your free calcium level starts to go up, and that can really help with your symptoms while you're waiting for somebody to definitively treat you. Obviously, if your child's able to, you want to try to give them some calcium, either through chewables or a liquid. And then when they're in the hospital, they need to get IV calcium. And sometimes that needs to be administered relatively quickly, over 5 to 10 minutes, to stop a seizure or acute tetany. But it needs to be followed up with a continuous infusion of calcium until you've got the oral medications on board for a couple days, because they don't start to work instantly. So now you've treated this acute low blood calcium. Conventional management, which I'm sure has been talked about a ton since in the last day and a half, but of course we give elemental calcium in divided doses. These are just sort of starting doses for children, but everything gets adjusted to the meds. But it's really important that calcium be taken with food, because not only is it helpful to raise the blood calcium, but it also acts as a phosphate binder and helps the phosphorus not be absorbed and go out into the stool. So calcium carbonate, they always say, oh, you got to take it with food. Calcium citrate, they say, you don't have to take it with food, but that's not directed towards the HypoPARA audience. That's directed towards people who are taking calcium citrate for other reasons, like osteoporosis. If you have hypoparathyroidism, you should always be taking your calcium with food, because it will help lower your blood phosphorus. And then again, when you're taking these calcium supplements, read the labels carefully, because everybody gets confused on how many milligrams they're on, because sometimes what the label says is the calcium carbonate content, but what you're interested in is the elemental calcium content. So for example, calcium carbonate is 40% calcium, elemental calcium, and you can see in the top left, it says there's 250 milligrams per serving, but when you look on the left box, it says 90 milligrams. So it's 90 milligrams of calcium, not 250. On the bottom one, it says there's 630 milligrams of calcium, but you got to look at the serving size. It's 2 tablets, so it's only 315 per tablet. And on the right, you can see the oral suspension for calcium carbonate, which is the one we typically use in children. It's 1,200 milligrams per 5 ml, per 1 teaspoon. But that's how much calcium carbonate. It's only 500 milligrams per teaspoon. So understanding the dose that you're taking or your child's taking is important. And the same thing we see with Tums. We see Tums 500, Tums 750, Tums 1,000. But that's not how much calcium's in it. The calcium is only 40% of that, so 200, 300, or 400 per pill. So back to conventional management, and then of course we all know we also have to treat the children with calcitriol or alpha-calcidol. Those are the active forms of vitamin D, but you can also use high doses of regular vitamin D, cholecalciferol or ergocalciferol, and I'll show you an example of that. So just keep in mind that vitamin D also increases phosphate absorption. Some patients also need magnesium, and you can consider being treated with thiazide diuretics in hypercalciuria, keeping in mind that there has to be a low sodium diet if you're taking those medications, and this treatment has not been systematically studied in hypoparathyroidism. So patient number 2 is a 16-year-old girl with APECED and multiple complications, including very significant malabsorption, and she gets admitted to the hospital all the time for hypocalcemia. And when the group contacted me about this girl, she was in the hospital, they couldn't get her calcium levels up. So I said, okay, she's got malabsorption, so calcitriol is short-acting. It has to be taken twice a day. If you are intermittently having malabsorption for any reason, APECED, celiac disease, inflammatory bowel disease, something like that, you might not always be absorbing your calcitriol regularly. But vitamin D, cholecalciferol, has a very long half-life and a wide body of distribution. So it's the kind of medication where you can give a high dose in somebody who has hypoparathyroidism, and the medication will stay around a lot longer. So if they intermittently don't absorb it well, they won't crash and be going in and out of the emergency room. And you can see in this girl, we started her on 50,000 units a day of vitamin D, and her calcium came up into the normal range. Now, doing this in somebody without hypoparathyroidism or somebody who has hypopara but has a pretty decent PTH level, that could cause hypercalcemia, so patients have to be monitored closely. Okay, I'm really bad at this. There we go. Okay, so the goals of conventional treatment, I think we all know with calcium and calcitriol, we're not making things perfect, right? Calcium still needs to be in the low normal range because patients will get high urine calcium. But for kids, so a couple important take-homes is make sure your doctor is looking at the appropriate age norms for calcium and phosphorus, which are very different than in adults, and also correcting 24-hour urine calcium levels for body weight. You can't use the adult normal range in children. So I monitor children frequently, at least every 3 to 6 months, sometimes more frequently in infants and young children. Try to look at the 24-hour urine if they're potty trained at least once a year, and I check more than just calcium because there's other things that can put you at risk for deposits and stones, and also doing periodic kidney ultrasounds. I know Megan already gave you a great talk about dietary measures, so I'm not going to go into this again, but definitely reducing salt intake. And actually, all of these things on this list are just healthy for everybody. They're not really special for hypoparathyroidism. Don't eat too much salt because salt goes out into the urine and it pulls calcium along with it. So the more salt you eat, the higher your urine calcium usually is. But these other things are just sort of generally healthy ideas. Just a second on special circumstances like illnesses. Your child really needs to be able to continue to take the calcium and vitamin D. And sometimes what I do is I switch them to chewable pills or liquid calcium because maybe they're going to tolerate that better or absorb it better. If they need surgery or if they're hospitalized for gastrointestinal illness, you got to go back to the calcium infusion in the hospital. And as I mentioned, you can consider high doses of cholecalciferol. We also have a lot of athletes in the hypopara community, so intense exercisers often also need additional calcium before, during, and after exercise, and I usually have them carry Tums on them. So what about giving them PTH? I'm not really going to talk about PTH. There's been a lot of discussion about that. This is specifically short-acting PTH, the 1 to 34 and the 1 to 84. 1 to 84 is not available anymore. And none of these studies have included children in them. So I'm just going to give a summary of the short-acting, 1 to 34 and 1 to 84. Come on. Okay, so bottom line is PTH can manage hypocalcemia, the short-acting, but the effect on urine calcium is variable. It does lower the urine citrate, which has the potential to increase calcium deposits. It increases bone turnover, and the long-term effects are variable. So that's something really important to consider in pediatrics, because this is not the same as becoming hypopara at 65. If you're talking about a child, you have to, like, what's your end game? Are you going to put them on this for 80 years? You need some really good data on that. Discontinuation abruptly of short-acting PTH can cause a hungry bone syndrome where blood calcium and phosphorus levels get quite low. So continuous PTH or long-acting analogs may be more physiologic, and we're seeing that with these new drugs that are being developed and recently approved for adults. And PTH therapy may improve quality of life, but at this point in time, given the lack of long-term data, PTH therapy really needs to be reserved only for children with refractory hypocalcemia. So just to conclude, just to remind everybody, medicine is an art. There's a lot of ways to manage a problem, and treatment really needs to be individualized for each child. And these published consensus guidelines that we're hearing all about, they're not including pediatrics because we just don't have that type of data, those studies, to really talk on that. So long-term, rigorous pediatric trials are needed with all of the exciting new therapies that are being discussed at this conference. So I'm very hopeful we will be including children soon. So now I'm going to turn it over to Dr. Kelly Roszko, who's going to talk specifically about ADH1 and our research with Encalaret at NIH. Thank you.
Okay, great. Thank you so much. Okay, these are my disclosures. So today I'm going to sort of divide this into 3 parts. First, we're going to talk a bit about the calcium sensing receptor and what that is. Then, what is ADH1? And finally, I'll be showing you some of our data from the NIH in calcilytics use in ADH1. So I'm sure you're all aware of this figure by now in this conference, but in states of low calcium, PTH is increased and secreted, and this acts at the bone where it releases calcium. It also acts at the kidney, importantly, and it's telling the kidney to hold on to the calcium from the urine, and additionally make active 1,25-dihydroxyvitamin D, which we all know is calcitriol. So taken together, it's all acting to increase the calcium. So what's the calcium sensing receptor and where is its role in that? Well, this is a calcium sensing receptor you can see here on the surface of a cell, and it's actually expressed in multiple cells, multiple places throughout our body, but really in high concentrations in the parathyroid glands and in the kidney cells. And that's what we're going to focus on is those 2 organs today. So in the parathyroid cells, when this receptor senses low calcium, it increases that PTH release. And similarly in the kidney cells, when it senses a high calcium, it's going to release the calcium into the urine. So again, acting in both places to normalize that calcium. So think about this like a cell is has some machinery, and the machinery makes PTH. So you can see that the calcium sensing receptor is there on the membrane or on the outside of the cell, and it's going to keep calcium in that really tight range of 8.5 to 10.5. We don't want to go too low or too high. And when it signals calcium, it tells the cell whether or not to turn on that machine and make parathyroid hormone. So in a sense, this calcium sensing receptor is sort of like a thermostat, right? In your house, you've got the thermostat. It senses that the temperature is cold. It tells the radiator to turn on. And likewise, when the calcium sensing receptor detects that low calcium, it's telling the parathyroid cell to make PTH, which is then going to bring the calcium back into the normal range by acting at the bones and the kidneys. So when, again, looking to that machinery, you have your thermostat here saying that it's low and turning off or increasing production of PTH to bring that back to normal. Likewise, when the calcium is higher again, that calcium is going to signal at the calcium sensing receptor and ultimately turn off the machinery so you don't get the production. And in the kidney, a similar thing is happening. When the calcium is high, the calcium sensing receptor is saying to get rid of that calcium and put more calcium in the urine. And this leads to hypercalciuria, or high urine calcium, which is something we're quite concerned about. And I'll be telling you more of that as we go. So now that we really all understand the calcium sensing receptor, I'll talk a bit about ADH1. So ADH1 is autosomal dominant hypocalcemia type 1, and Dr. Gafni just mentioned this in some of its inheritance pattern. So this is a rare type of genetic hypoparathyroidism with a prevalence of about 1 in 70,000 people. In ADH1, there's a change in that calcium sensing receptor. This could be called a variant or a mutation, and that's going to cause it to be stuck in this more activated state. So essentially, the body is tricked into thinking that the blood level of calcium is higher than it really is. So going back to our thermostat analogy, at this point, it's freezing in your house, but the receptor is sensing that it's not, and your thermostat's saying that it's 80 degrees, and unfortunately not turning it on. So this is the same sort of thing in these patients. In the setting of low calcium, the calcium sensing receptor is still sensing high calcium, and this is why the parathyroid cells are still turned off. Similarly, and importantly, in the kidney, the calcium sensing receptor is also overactive. So these patients are excreting even more calcium in the urine, and their urine calcium levels can become quite high and put them at risk for calcifications of kidney stones and nephrocalcinosis. And I'll mention more in a minute. So, as a quick summary, autosomal dominant hypocalcemia type 1, or ADH1, has a calcium sensing receptor that's signaling that there's plenty of calcium, but in reality, there's low blood calcium, low PTH, high blood phosphate, and high urinary calcium. So because this is a really rare disease, there are many case reports and case series about it, so sort of one patient describing two patients or a family, and we really wanted to set out a few years ago to tie this data together and look at a larger number of patients to see what was actually going on and what conclusions we could draw to help the whole population. So we went ahead and did a literature search, and we searched for all the terms that I've listed here, with a date range from 1996 to 2021. And then we collected the data from each study and put it together the best that we could. And this yielded 70 papers, so quite a bit of data that we were able to compile. And I'll give you a little bit of that data in summary, what we have time for in this presentation. So this is the calcium sensing receptor, kind of drilled down to a higher level. And you can see it's made up of over 1,000 tiny building blocks, and those are called amino acids. They are represented by each little circle in this diagram. And each of the red circles in the diagram is a place that we found was a potential variant or mutation that a person had with ADH1. You can see here on the receptor that there's an outside part of the receptor that's outside the cell or extracellular. There's a transmembrane part that's spanning through the cell, and this intracellular part inside the cell that's doing the signaling work. And I bring this up because you can see that unlike some other genetic diseases, in this disorder, these variants can actually be spread all over the receptor. So 54% were outside the cell, 33% in that transmembrane domain, and 13% intracellular. So actually all over can give this disorder of ADH1. And some of you who might have ADH1 might even know exactly your specific variant, and that can actually be quite helpful, because if you have a family member who you'd like to get tested, they can test just for that area or really focus down on that, which can help you to get a diagnosis quicker and accurately. So when we did this literature review, we found that 70% of the patients were diagnosed by symptom presentation. So they had symptoms of hypocalcemia, and they were then diagnosed with the disorder. 24% were diagnosed by family screening. So those are people who had someone else in their family determined to have it, and then they went back and found out that they also had it, or screened their children. And interestingly, 6% of the people in these studies were an incidental finding, which means the people were completely asymptomatic. They had no idea, and they went to get some type of routine blood work or blood work for something else and found out their calcium was low. So that was really interesting to us, and I bring that up because it really illustrates the wide spectrum of ways that people present, and that people have ADH1. And we see even across the same family members, siblings in the same family, there can be a drastically different way that these patients present with the disease and that they experience the disease. There were a really wide range of age of diagnosis. So for hypocalcemia, that went from birth all the way to age 66. And for the specific diagnosis of ADH1, even further, all the way to 77. And again, I think this illustrates the fact that people have varying degrees of severity. So people who are very mild might not get diagnosed with ADH1 until a very late age, or sometimes until their children are diagnosed. So a very interesting way that works out. Here are the initial presenting symptoms. You can see in the blue here that 27% of the patients were actually asymptomatic, so they had no symptoms at presentation. 33% had moderate symptoms, and 39% had severe symptoms. And those are symptoms such as seizure, loss of consciousness, laryngospasm, so the real severe. And we also found in that lit search that 38% of the patients, the most frequent initial symptom presentation was seizure. You know that seizure can be life-threatening, it's very dangerous, so obviously the goal is to try to diagnose patients before they present with such a symptom. And we're hoping that increase in genetic screening that you've heard about during this conference will help people to actually be able to identify children who have the disorder, et cetera, so that this severe presentation of seizure becomes less likely going forward in the future. So these are the complications I mentioned. Kidney stones or nephrolithiasis are when a stone forms in the tubes containing the urine, where the urine flows from the kidney. And the other thing is nephrocalcinosis, and this is where calcifications are formed in the kidney tissue itself. So in this diagram, the top 3 circles would be areas of nephrocalcinosis with calcification in the kidney tissue, and that lower circle would show an area of nephrolithiasis, or a stone forming, and the stones can sort of block the tubes here and have pain and lead to kidney disease, and they might need to be broken up with something called lithotripsy. So we looked at complications in this literature search, and we define complications as kidney stones, nephrocalcinosis, any type of kidney or renal insufficiency, and brain calcifications. And this is a graph showing the percent of treated individuals. So in treated individuals, their blood calcium is going to be brought up a little bit more by treatment. And you can see in the black bar, across all individuals, 76% of them had one of these complications. So showing that the complication rate is actually pretty high. And then we broke those up into saying which patients had normal urine calciums and which patients had high urine calcium levels or were hypercalciuric. And you can see that the normal urinary calcium patients, only had 47% of them had complications, but when patients were hypercalciuric or had high urinary calcium levels, 88% of them were actually having complications. So this further shows us the need to monitor urine calcium, especially in ADH1 patients, and to make sure that those aren't going too high. So to summarize our section on ADH1, in these patients, the thermostat is broken. They have the wrong set point with this receptor being too active, and the calcium sensing receptor is signaling that there is too much calcium, but not enough, and it's not going to release PTH. But important to remember, these patients have developed their normal parathyroid glands from birth. Their parathyroid glands are capable of making normal PTH, and there's been no destruction or removal of those parathyroid glands. So they're present in that person's neck, they're just receiving the wrong signal. And therefore, now I'm going to talk a bit about the use of calcilytics in ADH1. So back to the thermostat analogy, a calcilytic is essentially a tool here that can correct the broken thermostat. So really targeting exactly the calcium sensing receptor where that change or variant was. So calcilytics are going to turn down the calcium sensing receptor, and thus they're going to promote the production of PTH. So you can see those little green dots there simulating ADH1, the active receptor, and the calcilytic's going to come in and turn that down, making us create PTH again, and then bringing the blood calcium back up. And the same thing is going to happen to the kidneys, where you have those overactivated receptors that are putting calcium into the urine. By inactivating those, you're going to decrease the urine calcium. So this was really exciting for us because we had a way now to increase blood calcium while protecting the kidneys and decreasing that urinary calcium. So this was done with Encalaret. Encalaret is an investigational oral calcilytic, so it's a by-mouth pill, and we think it's a possible treatment for ADH1 by moving, sort of shifting these curves in the parathyroid and the kidney back toward the normal place for calcium secretion. And this is the study that was done at the NIH. This is a phase 2B study design. And I'll be going over this a little quick for time, but essentially we had 2 inpatient periods where there was individual dose escalation and titration. And then the patients went into a 24-week outpatient extension period, followed by a long-term extension, which was for 18 months. And today I'll be showing you those results after 18 months. The key was to look for safety and tolerability. And we also looked for blood calcium, urine calcium, and intact parathyroid hormone. And then there were several additional measures that we were able to also look at. These are the baseline characteristics of our patients, and I just put this up here to stress that these patients had fairly typical hypoparathyroidism levels. They were on fairly typical amounts of elemental calcium and calcitriol as treatment, and we had patients with 9 different variants of the calcium sensing receptor, so a lot of different people from that point. And 77% of the patients did have nephrocalcinosis or nephrolithiasis when they started. And here's our exciting slide here. You can see that Encalaret normalized the mean PTH and the mean blood calcium. And this is data going out over 24 months. You can see on the left-hand side is 24 weeks of treatment, followed by the months of extension here, up to 18 months on the right side of the graph. And you really see that at the beginning there was a baseline, very low PTH and low blood calcium, and it came right up into the normal range and was able to be sustained there in the normal range throughout the study. So very exciting results for us and for our patients. Equally exciting was that the Encalaret decreased the mean urine calcium into the normal range, and it was able to stay there through the duration of the study. And now remember, these patients have higher blood calcium levels, so we were able to bring up the blood calcium, but the urine calcium came down to the normal range. And there was no progression of renal calcifications on ultrasound observed at the week 24 mark or at the 12 mark of the LTE. And phosphate also decreased and magnesium increased for these patients. Encalaret had really minimal short-term effects on bone density, a tiny effect of a decrease at the total hip, but we'll be following this out to find more data on this as we go. And it was very well tolerated with no serious adverse events reported. So again, no serious adverse events and just very mild treatment-related adverse events of a little bit of hypophosphatemia or hypercalcemia. And these were fixed with some titration of the drug. So in summary, in patients with ADH1, Encalaret administered twice daily rapidly corrected and maintained mineral homeostasis within the normal range. And that was demonstrated by the increase in PTH, the correction of hypocalcemia, the normalization of the 24-hour urine calcium, the reduction in the mean blood phosphate levels, the increase in the mean blood magnesium, these bone mineral density scores that were stable except for that minimal decrease at the hip. And as I said, it was very well tolerated over those 24 months with no serious adverse events reported. So the study is now closed, and all of these patients have been transitioned into this long-term extension of the phase 3 study, which is called Calibrate. And we expect to have more data from that study in 2025, so it's ongoing. So thank you to everyone. Thank you to all of my colleagues at the NIH. And most importantly, thank you to all of our patients and their families who really make all this work possible. So thank you. And I'm going to hand it over to Dr. Iris Hartley, who is one of my colleagues from NIH.
Thank you so much. It's really great to be here. As Dr. Roszko said, I'm Dr. Hartley, and I'm an adult endocrinologist, and I'm a research physician at the NIH. I'm going to talk a little bit about calcilytics as a potential treatment for post-surgical hypoparathyroidism. Here are my disclosures. And I think you've kind of seen a slide similar to this already, and you know that PTH works to increase blood calcium. So in the setting of low calcium, PTH is released by the parathyroid glands, and that increases the release of calcium from bone, allows the body to hold on to calcium from urine and increases calcitriol or active vitamin D, resulting in an increase in calcium absorption. So we all know that if you don't have parathyroids, you can't make PTH and you can't do all of these things. So if you have low calcium, it remains low. Treatment with calcium and calcitriol requires a very careful balance between blood and urinary calcium, as shown here, and patient symptoms. So often we have to maintain people with a blood calcium in the low normal range, because if we push them to have a high normal range calcium, they can have a high urine calcium, which can result in kidney stones, kidney calcifications or nephrocalcinosis, and kidney injury. So I think it's really hard to mentally visualize this relationship between blood and urine calcium. So I like thinking about the body as a closed system, like a bucket. The blood calcium is represented by the level of water in the bucket, and that dotted line is the normal range for blood calcium. Calcium goes into the body through your food, and the amount that you're able to absorb from your food. So that's represented by the kind of drops of water coming in, and it leaves the body through the kidneys and the urine, which is represented by those little red holes in the side of the bucket. So this PTH is involved in both calcium intake and calcium output. PTH modulates calcitriol levels, so that affects the ability to absorb calcium, and it also acts at the kidney, affecting the ability to excrete calcium. So what does a hypoparathyroid patient look like? So they don't have PTH, so they can't absorb calcium as well. There's less calcium going in, and they have more holes in the bucket because they don't have PTH acting at the kidneys, so they have more calcium going out. And both of these things, less in and more out, result in a decrease in blood calcium level, right? The water level drops. This results in what we see in hypoparathyroidism, the symptoms of low blood calcium, the numbness, tingling, seizures, and tetany. So if you give patients calcium and calcitriol, you're really targeting the input, right? You're increasing calcium in to increase blood calcium levels. But as a result, you're not targeting the kidneys at all. And the urine calcium is going to increase. And that's why we see patients having high urine calcium. So what we have to do when we treat these patients is find a balance between these two second situations where you're trying to get the blood calcium just high enough that patients aren't having symptoms without causing high urine calcium. But there's another approach, right? So if you have somebody who has decreased intake and increased output, you can either increase intake or you can increased output, or you can decrease output. So you could be targeting the kidneys. And we already have a couple of strategies that Dr. Gafni has introduced to reduce urine calcium. You can decrease salt intake, and a low sodium diet results in decreased urinary sodium excretion, which decreases urine calcium. You can give thiazide diuretics, which is a blood pressure medicine that also decreases urine calcium, although it's not well studied in hypoparathyroidism. And it also has to be used in conjunction with a low-salt diet in order to work. That has some side effects and can cause low potassium and decreased blood pressure, which makes it limited to certain patients. So I want to introduce, well, it's already been introduced by Dr. Roszko, but there's another strategy to target the calcium sensing receptor, and Dr. Roszko did a really good job explaining what the calcium sensing receptor does. It's found in the parathyroids and the kidneys, and it's really determines how much calcium and tells the parathyroids and the kidneys how much calcium is actually in the bloodstream. Calcilytics work by turning down the calcium sensing receptors and make the parathyroids and the kidneys try to raise blood calcium, and that results in people who have parathyroid glands in an increase in PTH secretion and less calcium lost in the urine. So what do we know about calcilytics in human clinical trials? So in postmenopausal women, there have been they did trials for osteoporosis in the past in postmenopausal women with calcilytics. And in those women, they became hypercalcemic. They had high blood calcium. And this was due to both the increased PTH and the decreased urinary calcium. And Dr. Roszko showed in autosomal dominant hypocalcemic patients from overactive calcium sensing receptors, they did the same thing. Their blood calcium went up due to the PTH going up and the urine calcium going down. But Up to this point, calcilytics have only been given to patients who have parathyroid glands. As Dr. Roszko talked about, in ADH1, patients have parathyroid glands. The issue is with the calcium sensing receptor. But we wanted to know whether this would work in post-surgical hypoparathyroidism, where there's insufficient parathyroid glands. And this is especially important because it's the most common cause of hypoparathyroidism, making up 3 out of every 4 patients with hypoparathyroidism. And post-surgical hypoparathyroidism is a rare consequence of neck surgery, often due to thyroid resection. So what would be different about calcilytics use in post-surgical hypoparathyroidism? These patients have little to no parathyroid tissue. So even if you stimulate the parathyroid tissue, if it's not there, PTH is unlikely to increase by a significant amount anyway. So the main action will be on the kidney, the calcium sensing receptors in the kidney, to decrease urine calcium losses. And we have some reason in animal models to believe that this might work. In animals with post-surgical hypoparathyroidism, calcilytics were shown to increase blood calcium and decrease urinary calcium excretion. Bless you. And so what would this look like in my model? We would predict that calcilytics would plug the leak, resulting in patients being allowed to have a normal blood and urine calcium at the same time. So we'd be targeting the kidneys themselves. So that brings me to our current study of Encalaret and post-surgical hypoparathyroidism. Encalaret is an investigational oral calcilytic that is the same drug that Dr. Roszko was talking about. Our study is a small proof of principle design. We really just wanted to show that this could work. We are planning to enroll up to 15 patients with post-surgical hypoparathyroidism, and participants have to be generally in good health and not be on PTH or another investigational drug. The study is located at the NIH Clinical Center, just 30 minutes away in Bethesda, Maryland, and we cover all travel and lodging costs. So the study consists of, first, a screening visit. This is an outpatient visit at the NIH Clinical Center. They stay overnight just to do a 24-hour urine. They get 1 blood draw, kidney ultrasound, and an EKG. And this is followed by a Saturday to Saturday overnight stay at the NIH Clinical Center when they receive Encalaret, the pills, twice a day for 5 days. But we stop the Encalaret before going home. Again, this is a proof of principle design. We're not sending patients home with the drug. And we get frequent blood and urine sampling, and the blood sampling is taken off of an IV. They also do 24-hour urines and EKGs while they're inpatient. And once they get home, we do a lab follow-up just to make sure everything went back to normal as they transitioned back to their home meds. And then we give them 3 follow-up calls over the next 3 months to just make sure that everything is okay. So what were the potential drug-related risks in using this drug in this population? So this is based on the previous studies in other populations. Patients could have a high blood calcium. Now that's kind of what we want, but it could be higher than the upper limit of normal, which would not be ideal. They could also develop a low calcium as part of the study. If Encalaret didn't work at all, patients, we take them off of calcitriol and calcium, and their blood calcium could go down. And they could have a low phosphate. That's something that was seen in the ADH1 patients, and it's very unlikely in post-surgical hypoparathyroidism because that's likely mediated by PTH itself. And there were no other specific safety signals in the osteoporosis or ADH1 trials that we were worried about. So to address these risks, that's why we had the treatment phase of the study inpatient with very frequent monitoring. Our primary objectives were to determine if Encalaret could increase blood calcium while decrease urine calcium, and also to allow patients to achieve both a normal blood and urine calcium at the same time, to see if we could do that. And we wanted to explore if Encalaret had any other impacts on mineral-related measures. So we have currently enrolled and given drug to 7 patients, ranging from 26 to 69 years of age. All 7 of them were female, and they had surgeries between 3 and 12 years ago. And they had low calcium, low or low normal PTH, and high 24-hour urine calciums. And 3 of the 7 had already developed some level of kidney calcifications or kidney stones. So here are our results. So this is the blood calcium level as a function of time, and the gray lines, or the gray shaded area, is the normal range. And time 0 is when we gave the first dose of Encalaret. Along the top, you can see the individual exposure for each patient, and you can see 3 of the patients received drug for 2 days, and 4 of the patients received drug for the full 5 days. And the reason those 3 patients were stopped early, one of the patients actually did develop a high blood calcium, so we stopped the Encalaret early. We were able to do that very quickly. And then we actually rewrote the protocol to make the calcium supplementation easier to change quickly. So we didn't develop hypercalcemia in any of the subsequent patients. And then 2 of the patients were stopped because they met the primary and secondary endpoints, and we just wanted to see what the withdrawal of the drug looked like while they were inpatient. So you can see their blood calcium starting at time 0 were pushed into the mid-normal range from the low normal range. And we used calcium and in some patients a little bit of calcitriol to keep that calcium in the mid-normal range. And importantly, this is the urine calcium, 24-hour urine calcium with the normal range in gray. The urine calcium, even though the blood calcium went up, urine calcium dropped and remained low for the rest of the 5 days. And I think you can probably notice that there's a little bit of an increase at the end. That was due to those 3 patients who stopped early and the drug wearing off. 6 of the 7 patients were able to achieve normal blood calcium and 24-hour urine calcium at the same time. The 1 patient who didn't achieve that had a normal blood calcium and a urine calcium, a 24-hour urine calcium that was around low 300s, which is a little bit above the normal range. So we didn't expect PTH to do anything when we were giving Encalaret to patients with hypoparathyroidism, but we actually found this little bit of a spike that occurred at the 30-minute mark, which was a little unexpected. It happened in most of the patients, all but 1. There was this tiny little spike in PTH, and this didn't recur. So 30 minutes after the 3rd or 4th dose, they did not have a spike, and they kind of returned the PTH back to their baseline. And what we think happened is that the parathyroid gland that still is in, or the little bit of parathyroid tissue, has a little bit of collected PTH, preformed hormone, that when it's maximally stimulated, they release it, and they just aren't able to accumulate anymore while they're on Encalaret. So that was really interesting to see. And you can see that particularly the patients who have higher blood PTH levels at baseline, they really did have a spike even into the normal range. And we also looked at whether Encalaret impacted calcitriol levels. We didn't think that it necessarily would, but we wanted to see, and you can see that it didn't. Calcitriol levels didn't increase on Encalaret without PTH, and this decrease is because we stopped calcitriol in the patients. So this is more of a washout. So there were no serious adverse events. There were 20 mild to moderate treatment emergent adverse events, and if someone hasn't been in a treatment trial before, this means that anytime anyone developed any symptom, whether it was related to the drug or not, we wrote it down and included it as an adverse event. The only treatment-related adverse event occurred in 1 patient, and that patient developed the mild high blood calcium and associated headache that I mentioned before that prompted us to change the protocol. Her blood calcium increased to a maximum of 10.7 milligrams per deciliter, and it stayed very slightly elevated for about 60 hours after the last dose of Encalaret, and we stopped all calcium. She was able to maintain a flat blood calcium just above the normal range. Despite this high blood calcium, her 24-hour urine calcium was in the normal range, and it was actually less than 200 for the entire time until the last day when the drug clearly came off. So in summary, treatment of hypoparathyroidism with calcium and calcitriol can require a trade-off between blood and urinary calcium, and calcilytics, by decreasing urine calcium losses, may allow for higher blood calcium levels without raising the urinary calcium. Calcilytics have the potential to provide a really exciting new oral therapy for post-surgical hypoparathyroidism, and we are still recruiting, so please feel free to reach out if you have any questions or are interested. And thank you so much, especially to all the patients who participate in clinical trials. Thank you. And I've just, the next person to speak is Dr. Lionakis in order to talk about his work in APECED. Thank you.
Okay. Well, thanks for having me. It's much easier to follow the outstanding presentations and the setup that we heard from Rachel. So this part will focus on the subset that Rachel mentioned, which is autoimmune hypoparathyroidism. That is, the gland is formed, but eventually our own body, the patient's own body cells attack it as if it's an infection and destroys it. So a slightly different mechanism by which these particular patients who suffer from this monogenic disease develop this problem. So this is the long name that we abbreviate as APECED, or also known as APS type 1, autoimmune polyglandular syndrome type 1. And this is caused by mutations in a gene called autoimmune regulator, or AIRE. And as opposed to the genetic etiologies we heard earlier that Rachel discussed as autosomal dominant, that is, you need to have one copy of the gene being mutated. This is a syndrome that is called autosomal recessive, that is, you need to have both mutations inherited by each of your parents in order to actually get in trouble. Now, these patients fall under the category that we had earlier, not of isolated hypoparathyroidism, but rather an entire syndrome that includes hypoparathyroidism. It has a very classic presentation that, as we heard earlier, includes three major manifestations: chronic yeast infections, oral thrush predominantly, hypoparathyroidism, and then adrenal insufficiency. And this is a relatively characteristic triad, so it's not like the list in internal medicine of diseases that can cause these disorders is very, very long. Now, over the last 10, 11 years, we've enrolled over 200 of these patients at the NIH. This is a disease that is about 1 in 100,000, so there are probably a few thousand patients in the United States. And as we heard earlier, the syndrome can present with several disease manifestations. It doesn't mean, as we heard from Rachel, that every single patient will develop all of those disease manifestations. Actually, we see a very dramatic variation in how even siblings might develop 1 or 2 manifestations versus over 10. But you can appreciate here that in addition to endocrine problems with hypoparathyroidism and adrenal insufficiency being the more common, this is a syndrome that actually affects almost every part of the patient's body, from lungs to gastrointestinal tract to stomach to salivary glands, liver, and kidneys. And this is a disease that, if left untreated, it can actually lead to mortality in almost 25–30% of the patients because of excess inflammation that can attack the patient's body and cause severe, what we call multi-organ autoimmunity. Now, the reason why this disease happens in simple terms is because the immune cells, particularly a subset of them that's called T cells or T lymphocytes, which are cells that we all have in order to actually defend against infections, those cells don't get the proper education that they need to get in an organ that is called the thymus, which is sitting on top of our heart. And as a result of that, they're not able to distinguish between attacking an exogenous pathogen, such as a fungus or a bacterium, versus attacking the patient's own body. So this is an example of a patient's biopsy in the gastrointestinal tract. And I have circled there all of these purple cells that you see there are the patient's own body attacking the stomach and the duodenum, as if this is something that they should attack, which is usually an infection, causing all of this inflammation. And what happens in this disease is this infiltration, as we call it, of T cells in their own body causes tissue dysfunction. In the setting of parathyroid disease, this eventually causes destruction of the organ. So the patients end up developing complete destruction of parathyroid glands, PTH drops, and they develop hypoparathyroid-associated hypocalcemia. So over the years, by enrolling a large number of patients and working in the mouse model of APECED, what our key question was, can we understand what are the particular signals that these T cells that cause the tissue injury produce in excess that they can actually cause tissue injury? And if so, can we then intervene bring all of these signals down to normal to avoid all of this tissue injury. Now, we use words to communicate with each other. Cells make molecules. Parathyroid glands make PTH. Our immune cells produce molecules that are called interleukins or interferons. And one of them, which is called interferon gamma, is very, very important in all of us. When we get a viral infection or when we get a bacterial infection, it's produced in order to defend against those infections. So when this molecule called interferon gamma is produced in normal amounts, it's actually protective against infections. But when there is an excess production of this interferon gamma, that can actually cause tissue injury. And what you can see here in this slide is that what we were able to show over a course of several studies is that the key problem that these patients' immune cells have is that they produce a significant amount of interferon gamma. So these are flow cytometric plots. You can appreciate on the right side that there's a much higher amount of interferon gamma in T cells that do not have AIRE from these patients and mice. Now, when we know what the central problem in a disease is, perhaps then there are drugs that are there that are FDA approved that can help us in order to target this. So this is a busy slide that indicates that interferon gamma binds to its receptor, but downstream of binding to that receptor, there are two molecules that I have highlighted here. They're called JAK1 and JAK2. They stand for Janus kinase 1 and 2. And since 2011, the FDA has approved drugs. The first one was called ruxolitinib that has been used successfully to treat inflammatory and neoplastic diseases in different settings. So we reasoned that perhaps if we use these oral inhibitors, we can interrupt this excess interferon gamma pathway, bring it back to normal, and then restore immune function to normal levels and avoid this excess tissue injury in patients. So we first showed that in mice. So on the left, you see here all of these, again, purple cell collections are abnormal lymphocytic infiltrates that cause, in this particular case, salivary gland inflammation or Sjogren's syndrome. You see on the right, when we treat APECED mice with ruxolitinib, all of that goes away. That goes away in all of their organs, endocrine and non-endocrine, which then led us about six and a half years ago to start treating patients with this disease. So this is actually our first patient who had autoimmune alopecia. So again, here would be the same kind of purple cells would attack the scalp, not allow the hair follicles to generate into hair. This is not a wig on the right anymore. Wow. This is how a stomach of another patient on the left looks diseased. You can see the outlining of the blood vessels because of the extreme inflammation that causes thinning of the stomach walls, and on the right, restoration of normal gastric mucosa. Now, as I'll show you in the next slide, the two slides from now, which is my summary slide, we've now been able to reverse inflammation as treatment in people who have salivary gland or gastric inflammation or yeast infections. But when it comes to the parathyroid, when the parathyroid gland or the adrenal gland gets destroyed, there's really not much of a reversible process at that late stage. So if someone has autoimmune hypoparathyroidism for 10 years, it's highly unlikely that from this constant inflammation there's any leftover functional parathyroid gland that could potentially be restored. So about a year ago, we saw a 2-year-old child whose astute clinicians at UPenn had made a very early diagnosis of APECED on the basis that the kid had a lot of oral thrush and also had developed autoimmune hepatitis. So an astute team of clinicians thought of this disease. They tested the AIRE gene and they made a diagnosis at the age of about 1, which is unusual. Now, as you can appreciate on the left side, what you see on the y-axis is serum PTH levels, and you can see how these levels are dropping in the course of the duration of 2023 to levels that are undetectable, so that 3.3 levels are just at the level of detection of that assay. While at the same time, you see on the right graph, these patients' calcium levels hadn't dropped yet. But when we see this pattern of decline of PTH, what we anticipate in a patient like that is that there is already autoimmune destruction of the parathyroid gland, and in half a year and a year from now, that will destroy sufficient amount of gland function that then the calcium will drop. It's not uncommon, as we heard, for ADH1 disease patients to present with hypocalcemic seizures as a presenting problem. So what we decided to do is to start the patient on the same drug, ruxolitinib, here with the intent to not treat an established disease, because that would be too late for hypoparathyroidism, but rather with the intent to prevent further destruction of the gland, restore function, and prevent the development of symptomatic hypocalcemia. And what you can appreciate here at time 0, which is when we started ruxolitinib, that was December of last year, with that just within a month, the patient's PTH level came up to 11 and has really stayed in normal levels throughout, associated with a complete decrease in that interferon gamma signaling that we can measure in the peripheral blood. And you can also appreciate without any calcium or calcitriol or any intervention, his calcium and phosphorus levels that I'm not showing here have remained normal. Now, this is a patient N of 1. It's still only 1 year, but this, I think, provides a very promising proof of concept that in parathyroid disease and perhaps in adrenal disease as well, if one intervenes early, there might be a way to actually prevent the development of autoimmune parathyroid disease. This is in this particular entity and perhaps in other patients with autoimmune variety of hypoparathyroidism. Now, we've treated now 25 patients with this rare disease with ruxolitinib. All 25 patients have had life-transformative clinical responses in almost 20 disease manifestations, which has been humbling to see. I've highlighted in blue diseases that include some endocrinopathies, but diseases that even in internal medicine, outside of this rare disease, we actually do not know how to treat. So what's the treatment of Sjogren's syndrome or how to treat autoimmune thyroiditis or gastritis have not really been well understood. So again, the merits sometimes of taking care of a rare disease and how you can excerpt conclusions from a rare disease that might have far more overarching implications for more common diseases. So for example, for Sjogren's disease with our NIDCR colleagues, we're now implementing a JAK inhibitor trial for idiopathic Sjogren's, which affects about 4 or 5 million Americans. We also have a formal AIRE-approved clinical trial with this disease, and we're actively enrolling. And with that, I would like to thank the many people in my lab across the NIH and outside, and of course our patients who've made it possible. And I think that concludes our session.
Thank you so much. Anybody have any questions for anybody from the NIH team? Okay, let's go to Michelle.
So there is one question that just came in about what Dr. Lionakis was just talking about. So with that drug, because you said it only treats the other symptoms of the APS1, but it can't repair the parathyroid gland, could you take that with one of the other PTH therapies that are coming up?
So to clarify, what I meant is that in a child or an adult who already has had established hypoparathyroidism, I think the likelihood of that being reversed would be low. But if we follow the very last example, and that's hopefully generalizable, perhaps we can identify kids at early stages and maybe prevent the development of all of those autoimmune manifestations and not ever develop hypocalcemia. Now, in those who do, an approach that we heard earlier with decreasing urine calcium in secretion in the urine, that could be a potential way to do it. A lot of patients are treated with calcium calcitriol, or some are giving PTH. So I think in those situations where the glands are destroyed and there's no way to restore function with ruxolitinib, those would be the ways by which these could be treated, or symptomatic.
And Michelle, I think
Yes.
So the other question was, could you be on this drug to treat the other autoimmune parts of APECED, but also take PTH or Encalaret? And I think the answer to that question is yes. And I think a lot of your patients have been treated with PTH while they're because you can give more than one medication to treat the different conditions, so.
I would also add something that relates to also the case that Rachel showed. A lot of these patients get malabsorption, so it's very difficult many times to control their hypoparathyroidism from the standpoint that they don't absorb calcium calcitriol. What we've seen in all of these patients is because their enteritis completely remits, it's far more easy then to just keep them on a very stable lower calcium or calcitriol regimen without the problems that we see with fluctuation. So I think even in those who don't restore complete parathyroid function, we do see a major benefit in the ability to manage hypoparathyroidism much easier.
Okay, and then a very common question that is on here is we have a bunch of pediatric parents asking, what other pediatric trials do you guys have in the works? Because they want to get their kids in.
Well, I think we'd have to talk to some of the industry people who are here. I'm very hopeful that there will be a pediatric trial with Encalaret, at least in children with ADH1. And I think, I don't know if they spoke about that yesterday, but there's certainly, that is in the works. I don't know for the long-acting PTHs, including Yorvipath, which is approved, and the eneboparatide, which is still in research. I'm not sure if they're moving forward with pediatric trials for that, but I sure hope so.
Those are the ones I have online.
I know your drug helps reverse alopecia if it's an autoimmune condition. I know your drug reverses baldness if it's autoimmune. Have you tried it with just regular baldness, and does it work for that at all?
Unfortunately, that doesn't work for that. It does work for autoimmune alopecia outside of APECED, and actually there are now FDA labels for that in the last couple of years, but it does not work for androgenic alopecia.
And were you surprised that the drug worked for 29 different conditions? That seems like you hit the lottery with that.
I think the unifying underlying problem with this disease is that excess production of interferon gamma, and that really explains the entire syndrome. So I think in the era of precision medicine or personalized medicine, I don't know, I can tell you that I was expecting that, but I think now that we've seen it, we're both pleased, but also it does make sense that this is a one-stop shop that really explains the entire syndrome.
And you work with Candida. I've had nail fungus for years. I'm now putting Vicks on, but do you notice, I know that the hypoparathyroidism didn't cause that, but you know how some people are just more prone to it? What would you tell us other than lay off the sugar?
So in this particular disease, the yeast infections are caused by the exact same mechanism, meaning our own body T cells makes a lot of interferon gamma. It messes up the oral mucosa, the nails, and that's why they get it. Actually, that drug takes care of their fungi. In the general population, nail infections that can happen in up to 10% of individuals, the mechanisms there are different, so that wouldn't use that drug there. There are antifungal drugs that can help in some of these conditions. Happy to talk offline about that.
Thank you.
Okay, I think with one more question real quick.
Okay, I'm gonna give this person, all of a sudden 4 came in at once, but I'm gonna give this person special recognition here. Dr. Manstadt's sending things in from out of state. He said, Dr. Hartley, will you measure blood levels of Encalaret in your study patients? Because I'm wondering why the blood calcium levels stayed elevated for 60 hours.
Yes, we have measured that.
Okay, and then he says, Dr. Lionakis, truly amazing results. How did your young patient remain normal calcemic with undetectable PTH?
I think if we waited for another month or two, we would have seen decline in calcium. That's our prediction.
Okay, thank you all for that great presentation. We appreciate you.